Welcome to The Explainer. We all know iron is essential, right? But what if your body just held on to it? What if it couldn't get rid of it, and this thing you need to live slowly became toxic? That's exactly what happens in iron overload syndromes. Today, we're giving you the clinician's guide, the high-yield stuff you absolutely need to know to spot this in your practice.
So here's our game plan. First, we'll tackle the main problem, what happens when you have too much iron. Then we'll dive into the genetics of the most common cause. After that, we'll walk through exactly how you diagnose it, step by step. We'll cover the surprisingly simple treatment, and then wrap up by looking at other causes of iron overload. Ready? Let's get into it.
All right, so first things first, let's really frame this core problem. Iron is crucial for life, we get that, but our bodies are built to absorb it, not to excrete it. So what happens when that system goes haywire?
And that really is the heart of the issue here. Unlike pretty much anything else, we have no active, regulated way to get rid of excess iron. So if you absorb too much, it has nowhere to go. It just builds up, day after day, year after year, until it starts poisoning your organs.
Now you might be thinking, okay, but this has got to be super rare, right? Nope, not at all. For people of Northern European descent, the most common genetic form, hereditary hemochromatosis, has a prevalence of about 1 in 250. That is shockingly common. You are for sure going to see this in your clinic.
And the consequences of all that stored iron? They're serious. We're talking cirrhosis of the liver, which dramatically increases the risk for liver cancer. It can damage the heart, leading to cardiomyopathy and heart failure. And when it hits the pancreas and the skin, you get that classic textbook sign, bronze diabetes.
So what's actually going on under the hood here? Let's get into the why and the who behind this condition, focusing on the genetic and physiological roots of HFE-related hemochromatosis. It's actually a pretty elegant system when you break it down.
Okay, think of iron absorption from your gut like this. There's a gate, a protein called ferroportin, that lets iron into the bloodstream. And to control that gate, the body has a brake. That brake is a hormone called hepcidin. Hepcidin is the boss. It's the master regulator. When your body has plenty of iron, your liver pumps out hepcidin, which slams the brakes on, shuts down that ferroportin gate, and you absorb less iron. Simple, right? Well, in hereditary hemochromatosis, there's a genetic mutation that tanks your hepcidin levels. The brake fails. The gate stays wide open, and the body just keeps absorbing iron like crazy, no matter how much it already has. So here's the key clinical takeaway for you. The vast majority of cases you're going to see, we're talking 80 to 90%, are caused by someone having two copies, being homozygous for the C282Y mutation. The other mutations, they're really not the main players when it comes to causing significant disease.
Okay, let's make this real. You've got a patient in your clinic. They're tired, maybe their liver enzymes are a little off, or they mention a family history. How do you actually work this up? Let's walk through the playbook.
Your first move, always, is to order two simple blood tests, transferrin saturation and serum ferritin. If that transferrin sat comes back over 45%, your antenna should go way up. But, and this is a huge clinical pearl, remember that ferritin is an acute phase reactant. That means any inflammation, infection, or other liver disease can make it shoot up. So you always have to interpret it in context.
So, if those initial iron studies are looking suspicious, your next step is a slam dunk. Confirm the cause with HFE gene testing. If that test comes back showing the patient is a C282Y homozygote, you pretty much sealed the diagnosis. Okay, diagnosis confirmed. Now you have to answer the next question. How much damage has been done? And here's a number I want you to burn into your brain. A serum ferritin over 1,000. That is a major, major red flag. It means the risk of advanced liver scarring, cirrhosis, is incredibly high. For these patients, you've got to assess for organ damage, maybe with a liver biopsy or a specialized MRI.
Now here's a really cool diagnostic clue. Where the iron deposits tells you a lot about why it's there. In genetic hemochromatosis, the iron builds up in the main functional cells of the organs, the parenchyma. But, and this is key, it spares the spleen. In secondary iron overload from things like blood transfusions, the iron first gets gobbled up by the body's cleanup crew, the reticuloendothelial system, which is all over the spleen.
And wow, this MRI shows that difference perfectly. Iron makes tissues look dark on these images. So look at the left. You see a dark, iron-loaded liver, but the spleen right next to it looks totally normal. That's classic HFE hemochromatosis. Now look at the right. Both the liver and the spleen are dark. That pattern tells you this is probably not genetic. It's likely secondary iron overload.
So you've nailed the diagnosis. Now what? Well, the great news is that the treatment for hereditary hemochromatosis is ridiculously simple, low-tech, and incredibly effective. It's phlebotomy. That's right, therapeutic blood removal. The goal is super straightforward. You remove iron by removing the red blood cells that are packed with it. Every unit of blood you take out removes about 200 to 250 milligrams of iron from the body. So in practice, you'll start phlebotomy on your C282I homozygotes once their ferritin creeps above 300 for men or 200 for women. At first, it's pretty intensive, usually weekly. You're trying to get that ferritin number down into a safe target range of 50 to 100. Once you hit that goal, the patient enters a lifelong maintenance phase, just needing a few phlebotomies a year to keep things in check.
Now, setting patient expectations is absolutely critical, and you get to give them some really good news here. You can tell them that with treatment, their fatigue is going to get better. Their liver tests should normalize. If they have any early heart issues, those can actually be reversed, and that bronze skin color, that will fade.
But you also have to be brutally honest about what will not get better. Once cirrhosis is there, it's there for good. That horrible, debilitating joint pain, it often doesn't improve and can even get worse. And the same goes for established diabetes or hypogonadism. This just hammers home the point. You have to find this disease and treat it early, before the damage is done and becomes irreversible.
Okay, let's round things out by quickly touching on secondary iron overload. It's super important to know how to distinguish this from the hereditary form we've been focusing on.
This table gives you the high-yield comparison. Cause is genetic versus acquired. The iron deposition pattern is different, like we saw in the MRI, but the most critical distinction for you as a clinician is the treatment. Patients with secondary iron overload are often really anemic from an underlying blood disorder. You can't treat them with phlebotomy. You can't take their blood. So instead, we have to use special drugs called iron chelators that bind to the iron so the body can excrete it.
And this quote from the guidelines really says it all, doesn't it? Our primary job isn't just to treat the disease once it's full-blown. It's to find it before it causes permanent harm. It's about prevention. So what's the big takeaway here? Hereditary hemochromatosis is common. Its early symptoms are vague and nonspecific, but the damage it can cause is permanent. So the next time you have a patient with fatigue or joint pain or slightly elevated LFTs, are you going to think about it? Just keeping this on your differential and ordering 2 simple tests can literally change the entire course of a patient's life. Thanks for tuning in.